3.
Here we have Dr. Lakkireddy, a complex ablation specialist from the University of Kansas Hospital. Dr. Lakkireddy, if you would, we have 5 quick questions for you. Would you give us a brief history of your experience dealing with the esophagus during AF ablations?
Thank you, Mary. I think esophagus is an interesting structure when it comes to the collateral damage aspects of AFib ablation. For the longest of the time, I mean, we were aware that collateral damage to the esophagus is real, it happens, but then I think our understanding of the process was very limited. So I think for several years, I think we really ignored it. But then when we started realizing how important it is and the amount of devastation esophageal injury can cause, then it really compromises the entire safety profile of the AFib ablation in a big way. So as a result of which we figured out we need to monitor the esophageal temperatures. Then we also figured out if there is a way for us to really move the esophagus away from our target point of ablation while we are doing the posterior wall lesion set. I think it really would improve the safety profile of the AFib ablations to a significant degree. And so in the last 15 years or 16 years that the science has been really up and running, I think we've gone through several iterations, several tools, several hypotheses of understanding this link between the esophagus and the left atrium, and how to really prevent the damage, how to minimize the collateral thermal injury as well as the neural injury.
So what first intrigued you about the EsoSure esophageal retractor?
In the beginning, I was actually very skeptical about this device, right? So I say this, Steve Miller, the inventor of the device, was here in the Boston AFib meeting last year, and he was showcasing his device, and I looked at this, gee, what is this coat hanger going to do in moving the esophagus, and this must be really traumatic to the gut, and is it really going to do the job, right? So I think that amount of skepticism really inspired me to look at it in a very critical way rather than just believe what somebody's going to tell you. So what we did is we took this tool to our lab and we went back and we tested this in our own patients to really see if it works. In fact, I used one of my cardiothoracic surgeons while he was doing a video-assisted thoracoscopic procedure for a esophageal cancer surgery, and I asked him to put this device in while I was looking at the esophagus from the mediastinum through a VATS camera. And it is incredible to see the amount of movement that you can actually accomplish with a very simply designed tool. And that actually convinced me 100% that this could be a game changer in AFib ablations. And so then we took this tool back to the lab and we started using it. And in more than 90% of the times of cases, you are limited in terms of the esophageal temperature rise and whether you are able to really complete your posterior wall lesion set or not, as a result of which your acute pulmonary vein isolation basically becomes extremely difficult. And also your long-term outcomes also suffer in a bigger way. So since we started using the esophageal deviator, we were able to move the esophagus really well, and at the same time complete our lesion sets which we were having difficulties with, especially with the new contact force catheters. You have such phenomenal contact, you don't really require a lot of power, you don't really require a lot of lesion duration. So when you really cut short the power and the lesion duration on the posterior wall and you have a simultaneous temperature increase, you really need something to move that esophagus away so that it's protected and then you don't cause thermal injury to the gut.
So in summary, how many times have you used the EsoSure and how is your overall general experience
In our
been?
institution, we've used it more than 65 cases and our experience has been beyond positive. We actually have a prospective observation study that we have put together along with 4 other institutions in the country, and we have accumulated more than 150 cases by now, and our experience is phenomenal. We were able to move the esophagus in pretty much every case, some more and some less, but in the end we were able to really get our lesion sets completed and be able to get our pulmonary vein isolation done, which would have been difficult.
So do you have any tips for others who may be trying the EsoSure for the first time?
I think it's important to understand the device, and it's important to understand what your lesion sets are. So be prepared right from the very beginning. Make sure that you get the process down in terms of how to introduce the EsoSure device into the orogastric tube. What we found to be very helpful is if you prepare the OG tube ahead of time with a coat of olive oil and then flush it with air, it simply coats the OG tube nicely. And then the subsequent introduction of the EsoSure when you need it in the middle of the case will then become extremely easy, rather than trying to inject oil or the silicone sprays and other things that other people have tried. And being cognizant of the anatomy and then calling for the device without really wasting time will really help you to minimize the time delays, as a result of which you're not wasting 30 to 40 minutes on figuring out how to safely ablate your posterior wall, where you've got to use the EsoSure right from the get-go and then be done with your case faster, quicker, and then get your endpoints soon.
Right. So you're presenting a poster here at the 2017 AF Symposium on the EsoSure, and can you tell me summarize your results on that for us?
So we took these 4 institutions that had the early experience of using EsoSure. What we looked at is, were you able to successfully introduce the EsoSure to your target levels? That was one of our endpoints. Were you able to deviate the esophagus away from your point of ablation without causing significant temperature rises of more than 38 degrees centigrade? Were you able to accomplish acute pulmonary vein isolation in each and every one of these cases? These were our efficacy endpoints, and we met our efficacy endpoint in each and every one of these cases. And then we looked at safety endpoints with regards to complications from the usage of this device. Did people have any significant amount of trauma to the gut, which we assessed in terms of their symptoms? And I think one of the limitations of the study is we didn't do a direct visualization endoscopy on every single case to really prove or disprove of what we have done. But most of what we have done is assess the patient's symptoms. If somebody had symptoms, and we did endoscopies on these people. A couple of cases needed endoscopy. We didn't find any esophageal injury. And I personally don't think there is any risk of injury, because you are putting in a nitinol round-tipped EsoSure through a OG tube, which actually acts as a protective barrier, and so there's really no scope for any direct trauma, and that's exactly what we have seen. So you have the most simply, beautifully designed tool at a very cheap price that actually will help you to make your procedure safer and more efficient in a shorter period of time. You can ask for more.
Thank you. Well, thank you for your time.
Thank you.